Hello, my name is Dr. Pastel. In this video I will show you how I perform an MTP I arthrodesis using shark screw. Shark screw is made of allogenic bone and fully integrated into the patient's bone during the remodeling process. It also provides stability for secure fixation of the arthrodesis. At the same time, it ensures stable fixation of the arthrodesis. I'm excited for the procedure, so let's start.
The 51-year-old male patient is an excavator and truck driver who has been suffering from pain in his first metatarsophalangeal joint for many years. The joint is rigidly stiff, significantly thickened compared to the contralateral side, and repeatedly severely swollen. The X-ray clearly shows the severity of the osteoarthritis. The joint space is completely obliterated. We make a dorsomedial skin incision. The underlying joint capsule is split longitudinally, exposing the metatarsal head while carefully preserving the vascular nerve bundle. We release the medial and lateral collateral ligaments, ensuring that the joint capsule is fully mobilized around the metatarsal head and the base of the proximal phalanx. The capsule must be liberally detached along the bone, especially plantarly. The joint surfaces must be able to subluxate outward in maximum flexion, allowing the cup and cone reamers to be used safely without damaging the opposite joint surface. Now, we insert a central 1.6 mm K-wire axially into the metatarsal head. We determine the optimal reamer size based on the patient's anatomy. The metatarsal head is then completely debrided using the cup reamer. Next, we insert another central 1.6 mm K-wire axially into the base of the proximal phalanx. Using a cone reamer of the same size, the base is also fully debrided. Important: pressure during reaming must be applied only in an axial direction. Angled pressure could cause the base to fracture. Finally, we refresh the bone surfaces with a fine drill, leaving the bone dust in place to help fill the arthrodesis gap and minor irregularities. The metatarsal head and proximal phalanx are then pressed firmly together and temporarily fixed with a 1.6 mm K-wire to maintain stability, while also checking the rotation of the big toe. We confirm optimal plantar positioning using a sterile board. With the foot in a plantigrade position, the big toe, especially the distal phalanx, should make contact with the board. Dorsiflexion should still be freely possible at the IP joint. The placement of the K-wires for the shark screw works best when we imagine the dotted line shown on the left drawing. When viewed medially, this imagined line divides the big toe ray into two equal dorsal and plantar halves. The entry point for the K-wires for the shark screw lies exactly on this line. At a distance of at least 15 mm from the arthrodesis gap, we proximally place the first 1.6 mm K-wire at the midline, aiming its tip dorsally, distally, and laterally. The cortical bone is penetrated throughout. We then place the second K-wire, starting distally again at the midline, and aim the tip plantar, proximally, and laterally. The two K-wires correspond to the desired final position of the shark screw. We visually check the direction of the K-wires, with one running plantar and the other dorsally. From a medial view, they should not cross but remain nearly parallel. However, in the AP view, the K-wires do cross. We now check the position of the temporary K-wire again. If it collides with one of the other two K-wires, it must be repositioned. Next, we replace one of the two 1.6 mm K-wires with a 1.2 mm K-wire. The core hole is then gradually drilled over the K-wire, starting with the blue drill bit. Depending on the size of the bone, we decide which shark screw to use. Usually, we use the 4.5 mm shark screw, marked in red. For reasons of strength, the thickest possible shark screw should always be transplanted. Afterwards, we remove the drill and perform tapping with the corresponding color-coded tap. The depth of the thread cut is checked using the laser marking. It is crucial to flush the canal with physiological saline solution to remove the fine bone debris generated during tapping. The shark screw is then screwed in without much resistance using the screwdriver. This process is repeated with the second shark screw. Only now do we remove the temporarily inserted K-wire that held the two joint parts in place. After an fluoroscopic check, we saw off the protruding material at bone level. The transplant functions as a bone bridge and guiding structure for autologous cells. Post-operatively, our patients receive a soft forefoot cast with big toe inclusion for 6 weeks. Our patients are instructed to fully offload the foot for the first 4 weeks. In the last 2 weeks, the patient gradually puts weight on the foot while wearing a cast and an additional post-operative shoe.